Okay, so we're back. Jacob has decided to join us. So I'm back to do part 2. I just posted part 1, as well as 1, 2, 3 videos that go along with my videos. And then one that's just, if you have time, I did post my 600 pound life. So let me go back to the, let me share my screen and we'll go back to our PowerPoint. Actually, let's go here real quick. Wait, oh, it's not up here. Sorry. Just one moment, please. Okay. Okay, so we stopped off at oral cancer. So when we talk about oral cancer, the highlights from this slide and topic I want you to understand is that you may not be aware of is that, and I do actually have a story. When my mother was, I believe, 33, 34, she actually had oral cancer. She survived the cancer, and she, as most of you know, struggled with alcoholism. She also smoked cigarettes quite a bit. And when they did the surgery, I'm sure they do much more technologically inclined as far as, you know, looks and whatnot now. At the time, they basically pulled all of her teeth and just gave her dentures. Cut off a portion of her tongue, so it was a little bit harder for her to talk. She did, of course, we adapt to things, but they did attribute it to alcohol and tobacco use. There had been no history of this specific type of cancer in my family, especially at that age. So that was interesting to see. And she had been an alcoholic since the age, I believe, of 17. So 17 to 33, that's quite a bit of alcohol. And remember, alcohol is a poison. So that's going directly into your mouth. I mean, it's touching it. It's like a carcinogen as well as smoking. And usually, not always, but usually these cancers are spotted because we're not like always looking in our mouth. It's not on the outside. It's not where we can really see very well. It's usually seen more either on just random basic exams. You happen to yawn, someone sees something in your mouth, because they usually don't hurt. So it's not like a canker sore where you feel it and like, oh, this hurts, it hurts. And I've had patients that have become very anxious about that. Oh my God, I this must be cancer. And it ends up being a canker sore or a cold sore or something like that. So normally like the dentist or a surgeon, or it's just kind of a fluke thing where this is seen or caught, which is why usually it's caught late. And unfortunately, most people, I mean, and again, this is not my area, but I think in my experience, most people, because it's caught so late, kind of like pancreatic cancer, I mean, the chances of it spreading are more. So esophageal is right here. So of course the esophagus usually ends up involved. And actually that did end up happening later on in life. So just a real life scenario there. And of course you do a biopsy and get the results back. And then we choose from there how bad it is, radiation versus chemotherapy, both, what kind of, my apologies. If the patient may need to get, not everyone needs a trach when they have the surgery. This is just an example based on where they, did cut on the jawline. And then again, just depending on what's going on within any cancer. I think just one of the things that I want you to take away is that smoking and alcohol are huge contributors, as well as chew, that, what's the stuff called when people put it here, for oral cancer, so that we can educate our patients, of course. So we, of course, are always going to try to do education for cessation and, letting people know the risks of, and we all know, and it's hard. I mean, it's hard to say to somebody who has an addiction to nicotine, okay, just stop smoking, but maybe they don't know the risk, because we think of lungs usually when we think of tobacco. And actually someone made a really good point yesterday in clinical about, it's actually Andra had mentioned that, when we think of smoking, we think of the lungs, just lung cancer, but we were talking about COPD, and it was a really good point. Just to remember to always look globally and outside of the box, and not just, it's this equals this, because smoking has a lot. I mean, it affects our skin. It can affect our esophagus. It can affect our lungs in just more than one way, right? COPD, all of these other horrible things. It's not just lung cancer. So I wanted to kind of mention that as well. Esophageal cancer is similar again to most cancers. Unfortunately, it's pretty similar as far as oral cancer, because they are pretty much connected. Alcohol and tobacco use is a very large contributor, as well as Barrett's esophagus, which one of the videos does talk about, but that basically has to do when the cells in your esophagus, they change. And once they start to change, that is a particular indication that you are more likely to have those cells change into being cancerous later in life. The video goes into a little more detail, but that's when you hear that word, that's what that means. And then they have linked it to being overweight or obese. You have a higher chance of having or potentially getting esophageal cancer. Of course, this makes complete sense. Difficulty swallowing, feeling full, because we know where our esophagus leads to. From chapter 32 to our stomach, we're going to potentially feel full all the time. Potentially pain in chest, because your esophagus lies on your chest. So it may feel like your heart, but it's your esophagus that is feeling the pain. Food regurgitation, I think one of the videos talks a little bit about that, as well as potentially having foul breath, because you're having, if you really think about the anatomy and what's going on, and the food's not digesting as well, food's probably getting stuck here, and you're having cancer in this area of your body. I don't want to say it's rotting, but cancer is, it's your cells are not healthy. That, of course, probably isn't going to have the best smell, as well as potentially with oral cancer as well. And that's what's hard, because not everything is so black and white, like this equals this and this and this. And that's why we have to really think, not just see one thing and think, it's got to be that because they smoke, it must be lung cancer because they're coughing and they have chest pain and their lungs hurt. Well, it could be pneumonia and you not catch it and they die. You never know. So not sticking so much to it must be this because this looks like it. All of this is in the book, and really, this has been talked about before, but different types of tests that we do. We know what a biopsy is. We know what an we all say it different. Endoscopy is barium swallow. And the book talks a little bit more about different things that we can do. I think the most important one would be just to understand that we do special types of liquid where it can turn different colors and do different things as we do scans, basically, so that we can get a better look and actually see what's going on. We're not going to go over this because it's the same thing. Depends on the cancer, depends on the person, depends on what they want to do, but the treatments are basically the same. As far as the nursing care, of course, we always want to do our best to, and this is just my personal opinion. We are there to be supportive, right? And I don't think anyone wants to hear the shame and blame game. You better stop smoking. You're gonna and like what I do at work. That's actually one of my questions is when they come in. In our addiction program, we don't make you stop smoking. And I usually start by saying, I'm not going to give you a lecture. I'm asking the question just as a question because it's on going to be in your history. But do you smoke cigarettes or vape or any type of nicotine, any type of, and I kind of go through, try to make it as comfortable as possible, because smoking, especially even so more nowadays, I would say within like the last 10 years, this becomes so kind of scrutinized, because it is really bad for you as well as somebody else potentially secondhand smoke. So again, not shaming and blaming, and giving them, patients, the opportunity to talk about it. Like, yeah, this is really hard. And I usually will just, after they talk about it, say, if at any point in the program you're interested in stopping smoking, or you know, there's certain medications, you do things in the program that can help to lead to help with coping skills, just let me know. I'm not going to pressure you in any way. That's why I'm here. That's considered, you know, counseling or whatever. And we click a box saying that we said that. And it doesn't make people feel like you're looking at them negatively. And usually that actually helps patients more so ask for help. So just some of my own things that I think have been helpful for me as a nurse. Hiatal hernia, I did a video on. It's I think a really cool video, actually. I think you'll like it. It's a physician that talks about it, has all these pictures. Nursing care, it's very, very descriptive in the book. As you can tell, I'm being a little bit more not nonchalant, but I mean, you guys are almost done. This is GI's pretty, I don't want to say basic, but it kind of is. I mean, it really, we're, I think, more attuned, if you will, to our GI system in general, because all of us probably, especially in this program, have GI issues because we're an anxious mess and have had some of this stuff go on. And it is unfortunately a pretty common disorder as far as, you know, family members and whatnot, because of smoking and alcohol and things being at a high prevalence. I'm going to pause just really quick. Sorry, I need to, actually, I'll just take you with me. I need to plug you in. Otherwise, I'm going to lose you. I don't want to do that. My apologies. Okay, sorry about that. So, all right, where are we here? Okay. GERD, same thing. We talk about this all the time. We see patients with it all the time. I did post a video because I wanted certain medications to be talked about. I know that you've already had this in pharm. We give these medications all the time. So not that I don't want to waste my time going over it. I think it's kind of fun to hear from different aspects, not just one person's. Sorry, my dog is eating my food. Okay, that's fine. So GERD, the takeaway from this is the esophageal damaging. So being damaged. So if you have that constant stomach acid coming up and it's going into your esophagus, that's going to eventually break down, right? And that can actually cause that Barrett's esophageal stuff that I was talking about earlier, I could just say Barrett's. And so if you don't take care of that chronic GERD, you can, sorry, my dog just unplugged the video thing. Okay, we're doing our best here this evening. So we want to take care of that and let our patients know, like, it's really important that we, you know, take the medication. We don't want to scare them, but that we prevent this from happening, because prevention, like I always say, is key. And we don't want your cells in your esophagus to change. And over time, with constant gastric juices going in there, it can, and you have a higher probability of potentially attaining cancer. Like, that would be the verbiage to say, right? Let's see here. Yeah, all of this is pretty basic in your textbook. Again, it talks about the Barrett's esophagus. I kind of talked about it. The video talks about it, as well as your book talks about it. Excuse me. So they're considered precancerous, but like I said, meaning that it can turn into cancer doesn't mean they will. It's just a higher probability. It's a risk factor. I like that word better. Like, I wouldn't say precancerous to the patient. I would use a different, it's the same thing, but a different verbiage, just because I feel that would be more therapeutic. And there are ways to help with Barrett's, the tissue in itself, or they can ablate. I'm not sure if you guys have heard of ablation before, but it's kind of, I don't want to say a burning, but it's kind of like what they do, almost like a cauterizing, to where it can help to get rid of them for the time being. But then again, you have to keep up on basically controlling the underlying problem, which would be the acid reflux. GERD, I posted a really good video on all of this, the difference between antacids, so like, difference between Tums and Pepcid, and, what's the other one? There's a million, bajillion, and proton pump inhibitor, and they're so confused. They really are, even now, and I've been doing this a long time. They're confusing. Like, and it basically goes from the least, like Tums, right? It's more of like the balance, the pH balance, to making it to where your receptors don't create as much acid, all sorts of stuff. So I posted a really short and concise video that I think is really good, and I think it would be a really good reminder as far as your test for GI when you have your comprehensive final for the 25 questions. I'm not gonna, if I ask a question about meds, it's going to be basic. And it's going to be not because you can't handle more than basic, but it's going to be a basic question. It's not going to be anything that's going to throw you off, if you will. It'll be really straightforward. There's different procedures that can be done therapeutically. Your book does a really good job at explaining that. Of course, nursing diagnosis, acute pain. Oh my God, it hurts. If anyone's ever had it, I've never had a baby or been pregnant, but I do know, with all that extra weight pushing against, or we eat too much, or we just have it, it's not fun, and it burns, and it's not a good feeling. And of course they say avoid everything we love, basically, right? Lose weight, because again, obviously if you're pregnant, you don't, but if you're pregnant, that's why you're having is because you're having that extra weight push up. But it's the same thing for if you're overweight, you're going to have that extra weight pushing on that sphincter on the bottom of your esophagus and your your gastric area, your stomach. And then basically we tell you don't eat like spicy foods. That's such a big thing in most people's lives, like pepperoncinis or all those yummy things. Caffeine is huge in our society, so it can be really, really difficult. We're not talking about this. I'm mainly really want to focus on what, again, not that certain things aren't important. You can breeze through this in your book, but I want to focus on the things that are much more common. Esophageal varices, we will definitely talk about in chapter 35 when I post that video, not just because it has to do a lot with addiction, but it is a very life-threatening condition, and it's very important for you to understand, especially if you're ever going to work in the ED or any type of even clinic. This is going to be something, if you don't catch it early, your patient will probably die. So we'll definitely cover that in not the next video, but the next one. Gastritis, basically exactly as it is. Itis meaning inflammation, gast meaning stomach, so inflammation of the stomach. And this can be, you have the flu, sometimes they call that gastritis. And usually it happens from some sort of irritating substance. So it could even be food poisoning, or you ingested bacteria, or you have a virus, basically. Sometimes it can just happen just because you're secreting too many stomach hydrochloric acid. So antacids can be helpful for that, if that's the reason, or you can at least try it and see if it's not going to hurt you, right? Or it shouldn't hurt you. And a lot of what this has to do with is, again, we said inflammation. So that protective barrier that's in our stomach, it can be broken down, especially over time. If it's every once in a while, that's one thing, but we don't want to auto digest, right? So auto meaning basically digesting our own stomach. We do not want to do that. It can lead to perforation, which is I've had. It's not fun at all. As you can tell, I have a lot of GI problems. And you probably know that based upon my couple of my posts that I've left. So, and scarring. So, and the scars don't always, so if you have a scar, it's much more likely that you're more prone to potentially getting another ulcer, more perforations, tons of bleeding. It's just, you want to prevent this. We want to help our patients prevent this. This is all signs of having gastritis, very uncomfortable. You know when you feel this way, or so you know something's wrong. It's usually pretty prominent. Therapeutic interventions, of course, everything, that a little bit of what we mentioned before, irritating foods. We want to avoid alcohol as well as caffeine, which is not on here, and treat the cause. So what is the cause? If the cause food poisoning, then you just got to throw it up and get it out, right? And it takes its course. Same with the flu. Bacteria might be an antibiotic. If it's because you're just eating like bottles of sriracha, a week, avoiding spicy foods. People that enjoy like spicy foods or a lot of like olives or pickled foods, like I do. I love pickled foods, and I get really, 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 really sick. And some of you have actually seen that, but it's hard when you love something so much and it makes you sick. So, stomach. We went over this last week. Basically, what this has to do with like what the anatomy of the stomach is, pathophysiology. We've talked about, I don't remember if I did because I already taped this once. But from H. pylori, it is a breath test, and this is the number one reason why people get gastric ulcers. And they tend to usually be in the lower part of the stomach. And there we go. And the treatment's just antibiotics. Boom, done. It's bacteria. You have it, and it's just, to me, crazy like how easy it is to treat it. And I wish it was that easy to treat the other kind, because the stress ones are not that easy to treat. I mean, hydrochloric acid is just spitting out into an empty stomach if there's no food in there. And a lot of times it's one of two things. If you're really, really stressed, you either overeat or undereat. If you're one that undereats, what do you think is going to happen? Hydrochloric acid is being pumped into a stomach with nothing in it, autodigestion, right? So that's why they call them stress ulcers. So of course we want to try to give as much care as we can and treatment, and talking about different prophylactic medications. Let's stay on top of this. We don't want you to have autodigestion, and then explaining what that is. Peptic ulcer disease, I did put a video up on there as well. I feel like a lot of us are very familiar with this, but I just want to point out H. pylori again, and that is, like I said, a breath test. It's the number one reason people get gastric ulcers, and it's treated with antibiotics. And then you are more at increased risk for this if you use a lot of NSAIDs, which we know are non-steroidal anti-inflammatories. Drugs, sorry, I was gonna say disease. So like ibuprofen, Motrin, things like that. So I don't smoking. Oh yeah, I did. I'm sorry, I was just having a thought, because I've treated a couple of my patients have had this, and it when I first learned about it, it shocked me. Like, oh wow, that's interesting that would give you more of a chance of getting a certain type of bacteria. I don't know. Maybe I just find certain things interesting. Hopefully we all know where our stomach is. I know we all know where our liver is, because I've asked, well, if you've ever had me, and so your liver's in your upper right hand quadrant, your stomach is in your upper left hand, liver is in the upper right quadrant. Yeah, that's what I said. And then your stomach is in your upper left. And duodenum is the small intestine, basically. And you'll know the difference between the ulcers based on the type of symptoms that you're having. So when you have a gastric ulcer, you're going to have more of an increased 1 to 2 hours after meals, or with food, you'll have more pain. And then with duodenal, it's going to be increased 2 to 4 hours after meal or in the middle of the night. So that's like one question we would ask a patient, right? So that we could help maybe like know a better treatment plan and kind of start getting things going. And all of this we've talked about. This your book has a really good description. You're not going to be tested on it or this. The video talks about this. I'm not going to test you on it, but I do think it's important that you have a basic understanding what the difference between like, I say it wrong, but like, well, it's Prilosec, omeprazole, Tums, and like famotidine is. Like, I think that's important to kind of know at least one of the drugs from each of the classes. I think that would be something that would be important. Doesn't mean it's going to be on a test. I just think that it would be important to know, and especially where you end up working. Like Protonix is Kaiser, for whatever reason. I remember when I was there with Miss Jan, and that was, I think, one of my first meds I pushed IV. Already talked about this. This is very, I think if you didn't know this, we would be in trouble. Gastric bleeding, not good. Very, 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 very scary, especially if you start vomiting blood or if you're defecating blood. It's extremely scary to see, especially if you have not seen it before. You definitely need to get that person seen, because it could go from mild to severe in just the blink of an eye. And hypovolemic shock is a huge potential risk, and losing all of that blood. So we need to really get that treated if that is what is going on. Of course, we're not going to give this person anything by mouth. We're going to pump them full of fluids, electrolytes, catheters going in. We're measuring, fluids. We're potentially, NG2. It just depends on what's obviously going on, but definitely deficit of fluid volume. And it's a horrible feeling, shaky, weak, awful, 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 awful. Gastric cancer is all the other ones that we had talked about earlier, depending on what's going on. Unfortunately, this particular cancer tends to metastasize and does tend to not, I don't like when people say, is it a good one or a bad one? It usually doesn't have a good outcome, unfortunately. So, and for whatever reason, men are at greater risk. And H. pylori and having, lots of stomach issues, of course, is going to put you at more risk to potentially get gastric or obtain gastric cancer. Pretty much this speaks for itself. There's really no early symptoms. It's more about it's kind of like pancreatic cancer. It's more of the later symptoms where you don't want to eat, the indigestion, you start losing weight, you feel really, really sick, and things don't help. So antacids don't do anything anymore. Nothing that worked before is working anymore. So this can tend to be the denial phase. And it, we're human. We're scared. And it's usually one of two things. There's people that will go to the doctor because they're scared, or those people that are in denial and they don't want to hear it. And then they're, we never shame that either, right? Patient comes in, of course, we're going to do several different types of tests depending on what's going on and what we think is going on. There's different types of therapeutic things that we can do, which we've talked about with every cancer. There have been, because we've talked about gastric bypass, of course, we can do a partial removal of the stomach or completely remove it, because we can connect the small intestine and do all sorts of, like, basically, I think I have a picture of it. Yeah, this actually was on my, what's that thing called you take at the end? NCLEX, the Billroth. So Billroth 1 and Billroth 2. So knowing the difference between the two, so like what parts are actually taken out of the stomach. So Billroth 1 is less, Billroth 2 is more. And then here's some pictures of kind of showing how they basically reconnect your digestion, oh my goodness. Been talking all day, clinical digestive system. And so that could be a potential if the gastric cancer is operable, then that could be a potential hopefully, right, to do a gastrectomy. It doesn't make life easy. Again, we have to relearn how to live and eat and do all of that kind of stuff. They have some good pictures in there. We don't need to talk about this. Of course, we know what we're going to do. We're going to monitor pain, all of this stuff we already know. Look at the site, make sure there's no infection, monitor vital signs, make sure fluids and electrolytes are good. Complications, of course, same thing. We already know that there's probably gonna, or potentially we could have a hemorrhage. We want to look for gastric distension because we're looking for, is there bleeding going on? Is there swelling going on? Dumping syndrome is very common with any sort of gastric, meaning that we digest things too fast and then we're not getting any nutrients from it, right? We don't want that. And that can lead to potential pernicious anemia. And it just, we're looking for all of these complications. We're definitely listening to bowel sounds. We're asking the patient how they're feeling and making sure that we're doing our job diligently. So that is the second PowerPoint. I'm going to stop my share. So please watch, hopefully you're watching this. I know we went a little bit fast. I just feel that it's pretty straightforward, and I did a whole video that didn't record. I hope that you got something from this, the highlights, as well as the videos that I posted. So please let me know. And if you have any questions, and I think I'll post a discussion board as well if there's any questions too. So, okay, I miss you guys. Thank you so much. I hope you're all doing really, really well. And it's almost done with clinical. Oh my God. Okay, good night. Bye.